First speaker, it's a pleasure to introduce Dr. Norah Terrault, who's actually our new GI chief at USC, and I wanted to also welcome her to the Southern California, the illustrious Southern California GI community, and she's going to be giving us a talk on hepatitis B and hepatitis C. So, thank you.
Yeah, thanks, Jeff. All right, well, great. Thanks so much, Jeff. And I'm really delighted to be here and loving my first few months in the LA area. So thrilled to be part of now the Southern California Society for Gastroenterology. So thanks for the invitation, and look forward to meeting many, many more of you on a one-to-one basis. So just to sort of set the stage, you're all very aware that there's, for several years now, we've been under this umbrella of working towards viral hepatitis elimination, and the goal is to do that by 2030. And this just to remind you that in terms of what that means, elimination doesn't mean there'll not be any hepatitis in the world, but really what it means is that we're going to reduce the number of new infections by 90%, and that we're going to reduce liver-related mortality by 65%. These are very ambitious goals, and the CDC has embraced them here in the US as well. And what I want to show you on the next slide is, again, recent data. These were not presented at DDW, but a meeting just before that. There was a meeting between EASL and AASLD on where we were in terms of hepatitis C. And presented at that meeting was this modeling data that looked at, well, how are countries doing in terms of being on track towards elimination? And you can see that in green at the top are the countries that are really on track, likely to actually achieve these endpoints by 2030, and they include Iceland, Finland, Japan, Switzerland, and South Korea. And then there's a group that's in sort of the orange, yellow, which are pretty close and making good progress. And then those in red are those that are not even going to make it. They're just not going to make it, and they're not close. Now, the US is at the bottom. That doesn't mean they're the worst. They're doing it alphabetically here, so it looks that way. But the message is that even if you project out to 2050, that we're not likely to achieve our elimination goals unless we make substantive changes in how we're thinking about doing elimination. And so this was actually presented at a meeting this year, but it's in the interim been published, and it's just to highlight where are we in terms of the gaps in getting towards elimination. And probably the biggest one that remains is that individuals remain unaware that they are infected. So you can't initiate anything unless somebody is diagnosed. Now, this largely falls into the camp typically of primary care physicians, but I think that we as gastroenterologists and hepatologists continue to have to kind of carry the flag in terms of the importance of doing screening. So you can see for hepatitis B, about 1/3 of patients unaware that they're infected. This is data from NHANES, where they test everybody and then find out. They actually ask patients, were you aware that you're infected? And only 32% were aware. And for hepatitis C, it was somewhat better, about 50-50 were aware. But with hep C, I think the more discouraging thing is that of those that are aware, only 45% of those individuals had gotten to treatment. So we still have a long way to go if we're going to get to those elimination goals, both of reducing new infections, so you can't prevent new infections if somebody doesn't know they're at risk for transmitting, and in reducing mortality. Okay, so with that as backdrop, just to give you a little bit of an update on both hep C and hep B, I'll start with hep C. I'm going to draw a little less from DDW and more from the EASL meeting. So for hepatologists, that's sort of our spring meeting of probably larger, greater importance is the European Association for Study of Liver Disease. So you're going to see that I'll pull a lot of data from there. I'm going to touch base on the changing epidemiology. This is US data and really with the implications for screening, and then move forward in terms of talking a little bit about treatment and some of the nuances there. So the most important thing is that the way we think about hepatitis C in the United States is changing. This is really reflective of the opioid epidemic and the fact that we've got this whole new cohort of individuals who are between the ages of 20 and 40 who are now infected. And that is partly why we're not really reducing our number of new infections, is that we're getting too many new ones within that demographic of the opioid epidemic, and so that we're not really making headway there. So if you look at these graphs that look at sort of the age of those infected in the United States, you can see that 10 years ago, it was that baby boomer group, and that's why we made changes to screen baby boomers. But now if you look at 2015, 2019, we now have this sort of bimodal distribution. And in some states, that it's getting to the point where actually now that younger group is outnumbering the baby boomers. So 30,000 new infections per year, so we're sort of not making progress, and really the drive here tells us that maybe we have to think about doing our screening differently. So as you know, the CDC did recommend this change in terms of screening the baby boomer group, so that was a very important next step. We've always recommended risk-based screening, so that still remains in place. But the new items that you may not be aware of is the ASLD. This is not endorsed yet by all groups, but they now recommend screening all pregnant women in a way to try to capture that 20 to 40-year-olds that are presenting in the context of pregnancy. And they also are recommending sort of an opt-out approach to those that are in jails and prisons because of the prevalence of hepatitis C being so high there. But I'm going to show you one other group that I think is really relevant to the LA area, where we have this very diverse group of patients, many of whom are foreign-born, is that many of those individuals don't really fall into this risk-based screening because they acquire their hepatitis C typically in the country of their origin through medical and dental care. Because on a global basis, that is the most common mechanism by which hepatitis C is transmitted, is in the context of basically dirty needles or equipment that's used to do dental and mental care. So you have to think about that in many of your foreign-born. And again, this is just highlighting sort of gaps in care, and I just wanted to highlight on the first set of circles on the left, that among foreign-born, these are foreign-born that are known to be infected, 65% of Hep B patients don't know they're infected, those that are foreign-born, and 74% of those that have Hep C. So this is an important demographic, I think one very kind of relevant to Southern California, for example, where we have a lot more foreign-born individuals. We have to think about foreign-born as being one of the reasons to think about screening for hepatitis B and hepatitis C. Okay, so that's my little sort of update on screening. The other, I think, major move in Hep C is that we're just moving to making it simpler. And simpler to the point where anyone can do it. Primary care, nurse practitioners, certainly gastroenterologists can do it, but with great ease. And the way that we're simplifying it is moving towards pan-genotypic regimens, so regimens in which it doesn't matter what the genotype is. You don't really even need to test for genotype, in fact. And where it's a very simple sort of, once-a-day dosing for either 8 or 12 weeks, and you basically get a very high rate of success. And the two drug combinations that fit into this very simplified regimen that we're trying to move towards in treatment-naive patients is to use soft valproatovir or glucophage. So really, you're going to see the guidance move towards this very simplified approach. Sort of pick a drug, both work great, works in every, if this is in your non-cirrhotic patients, you can just sort of move forward. Don't have to do a lot of testing. Figure out the stage and move forward with doing treatment. So I think that this movement towards simplification is really an important means of us getting more patients treated more quickly. A little bit of data, now this is from the EASL meeting, just to say that these two regimens, these pan-genotypic regimens, work extremely well. If you use them in a across global population, so all genotypes, as shown in the bars at the top there, these are different genotypes from 1 through to 6, different stages of disease, you can see that you're getting very high rates of sustained virological response. So, basically 95 to 99% in most of the groups. So this is very straightforward. Pick your regimen, treat. This is what you can expect to see. And we look at the other option that's pan-genotypic, glucophage, same thing. This is 16 unique cohorts that were kind of put together to look at what are we seeing across a very large number of patients. Again, regardless of genotype, you see this very high rate of SVR. Now, I'll emphasize that most of this real-world data is in individuals who, again, have not previously been treated and are without cirrhosis. Although cirrhosis, as well as if it's compensated, actually is also relatively straightforward to treat. But we do need to know stage of disease, cirrhosis, no cirrhosis, in making treatment decisions. One of the other advances, this comes from the ASLD meeting last year, so you probably got some wind of it, but I'll just remind you about this. It's pretty exciting data. It's really because right now for individuals with cirrhosis, all of the treatment regimens that are pan-genotypic would recommend 12 weeks, whether it's glucophage or soft val. But there is this interesting study presented on using GP, I'll abbreviate, in compensated cirrhosis for 8 weeks. And that's kind of an interesting idea, because then it would make it so that the GP regimen could be used across basically any patient, cirrhosis, no cirrhosis, for 8 weeks. So these are kind of exciting data that kind of push us towards thinking whether that might be possible. And certainly, as you can see here, this looked very exciting. The regimen performed very well. I will highlight that genotype 3 is not in this study, and that's a very special group because genotype 3 turns out to be still the one that can be a little bit tricky to treat, where we see slightly reduced SVR rates. And so I'd say this is interesting. We're going to have to be on the lookout for the genotype 3 data that are going to be forthcoming, but potentially could even simplify our treatment regimens further. The other thing that I think helps is that we used to have great concerns that if somebody had renal insufficiency and was on a sofosbuvir-based regimen, that the package insert said basically you can't use a sofosbuvir-based regimen. So we were all very eager to see data that helped us to understand whether we could use sofosbuvir-based data in patients that had renal failure, those that had eGFRs less than 30, or those on dialysis. And we now have those data. Those have come out in this past year. This is the one in dialysis patients. We also have one with renal insufficiency. And the most important thing here is not that the SVR rate is excellent. I think we wouldn't be surprised by that. But more importantly, it looks safe. And I think we were needing to see these data, have more confidence around being able to use sofosbuvir-based regimens in patients with renal insufficiency. So again, kind of doing away with things that used to limit us in terms of being able to provide treatment to a broader range of patients. And then finally, there is going to be a few percentage of patients who are going to fail treatment. And so what do we do with those patients? And I would say that in general, the most sort of favored approach is to use the triplet of soft-valvox, sofosbuvir, valproatovir, voxilavir. You're sort of taking a drug from each of the classes and putting them together into a 1 pill a day regimen. And here is data. This was presented, but now just recently got published. This is from the VA, where they looked at their experience with doing retreatment of individuals who'd failed a prior DAA regimen. And really to highlight here that our rescue therapy is also highly effective. But the interesting thing that's coming out, and I think we just have to be aware of the data as we look at retreatment. I think this is where this falls into the specialist group. So this is where you're going to see these patients, or I'll see these patients, because they failed that first round of treatment, and now it's like, what do we do next? And I think we generally do resistance testing. We sort of be selective about what we're going to look at. And there's a little bit of an interesting aspect that came out of this study, and that is they showed that overall the SVR rates are very high. You can see genotype 1, 2, 3, 4 varies from sort of 89 to 100%, modest numbers in some of those non-genotype 1 groups. But what they did find in this study is if somebody had been treated before with soft val and then was retreated with soft valvox, that they did see lower SVR rates in that group. And you can see the genotype 1 at the bottom, 78.9%, genotype 2 and 3. Numbers are modest because, of course, it's a large experience of the VA, but still relatively small numbers. But a suggestion that maybe that might turn out to be a group that might be at higher risk of not responding to soft valvox. Maybe we're going to need to add ribavirin. Maybe we're going to have to think about other permutations. And there are some other options that are being put forward, including the use of GP with SOF as an alternative rescue regimen or salvage regimen. So we've got some things to work with, but this is the kind of nuances now that we're getting into with our treatment. The last thing I want to talk about, and of course there's been publications that have come out, but this was very exciting at the meetings, is this idea of we're so confident now about being able to treat patients that now we're willing to give somebody who doesn't have Hep C, give them Hep C and then treat them. And that's probably really relevant in the setting of transplantation. And these were 2 studies that were presented on the left in hearts and on the right in lung patients, in which they took individuals who didn't have Hep C, gave them a donor who was known to be infected with hepatitis C, and then started HCV treatment pretty much around at the time of transplant or shortly thereafter. And impressively, you can see in the hearts on the left, they had 25 patients in which they did this. They treated them with GP for 8 weeks, starting literally on call to the operating room, and they had 100% of their patients that responded. So beautiful results, I think. And they also showed in this study that it actually reduced the waiting times of the patients who were on the waiting list for a heart. Maybe a little bit more cautionary tale was the group from Toronto presented on lung transplants. They also had about 20 patients, but in their group, they started soft val, but they didn't start it right at the time of surgery. They actually started it on average about 3 weeks after surgery, and they had less success. They had 2 out of 8 patients who relapsed, and one of the relapsed patients actually developed a high level of resistance, and they had 1 patient who developed a very severe form of recurrent hepatitis C called fibrosing cholestatic hepatitis. And that I think is just to remind us that we've got to be, if we're going to do this, we have to be willing to treat early, drugs have to be accessible, et cetera. But it's pretty exciting to think about being able to potentially do this in a greater proportion of recipients. And so now there are several studies ongoing at our center and others where we're actually studying this idea of giving HCV-positive organs to HCV-negative recipients. And as you know, there was a very recent publication on the same in the New England Journal of Medicine. So something that I think we want to make our patients aware of, because this is one way to shortcut their time in terms of getting to transplantation. So just to sort of summarize some of the sort of, I guess, hot areas in HCV management, sort of based on the spring meetings. This issue of underdiagnosis still is, I think, important. We need to broaden our screening methods. There's now talk about, should we implement a one-time screening of every adult over 18 in the US? It's on the table as consideration. I want you to think about the foreign-born, especially here in the LA area. And another group I think of importance is pregnant women. Treatment is becoming very simple. If you're not in treatment now, you should get into it. It's pretty straightforward. It's simplified to 2 pan-genotypic regimens, very high rates of SVR. Still need to know the stage, and that's why I, as a hepatologist, I still advocate for that. And the reason stage is so important is that even after cure, people with advanced fibrosis, meaning stage 3 or 4, still need surveillance for liver cancer. So that's why the whole staging is still really, really relevant. Very few difficult to cure groups, in fact, really. We can treat really every stage of liver disease, even those with decompensated cirrhosis, those with renal failures, those with co-infection for HIV. There really is there's a very small group of patients that are challenging that are left. The DAA failure is still one where I think we're learning what drugs might be perfect, but we do have very good salvage regimens. And then just to make you aware of those HCV-positive donors that are increasingly being used. Now I'm going to shift to hepatitis B, where I think things have been kind of stagnant, I would say, in HBV for many years. And I'd say we've got some very exciting times, because now the whole idea of cure for Hep B is definitely on the forefront. So I'm going to chat a little bit with you about sort of some updates on the who to treat. There's some interesting data evolving on what we treat with, Entecavir versus Tenofovir-based therapy, and then a little bit about STOP. And I'm going to close with just giving you a little flavor of the new drugs that are in the pipeline. So in terms of who to treat with hepatitis B, as you all are very aware, the treatment guidelines recommend that right now we target those that have active disease. That means somebody whose ALT is elevated and their HBV DNA level is sufficient that you believe the Hep B is causing the ALT elevation. So for e-antigen negative patients, that's over 2,000. For e-antigen positive, it's over 20,000 IUs per ml. I think the group that's always makes people nervous, and where there's often a lot of discussion about should we treat, is the immune-tolerant adults. So what are those individuals? Those are individuals typically between the ages, of 18 up to, 40. They can even be older than that. But they have very high levels of virus, typically in the millions to billions. And their ALT levels are normal, meaning 20, like normal. And they're young. And really, it's representative of a time where there's a lot of virus, but there's not a lot of immune response to that virus, so there is no ongoing liver injury. So the guidelines have not recommended that we treat these individuals because the benefits of treatment are not established. They are actually quite challenging to treat in terms of getting them suppressed. And this concern is that you're treating without sort of a clear benefit. But I would say that there's a sort of an evolution in this group. EASL and APASL, which are the other societies, in the ASLDs always said, if you get over 40, you should probably think about treating, because generally those individuals start to show some signs of disease. EASL and APASL starting to sort of lower that number. They're saying if they're 30 and above and look like they're immune tolerant, you might think about treating those individuals. In fact, EASL says anybody over 30 who's immune tolerant, you should treat. So that's very different from what ASLD has recommended, and I just wanted to share a little bit of data about kind of why that's moving in that direction. This has been published, and I think was one of many papers that are suggesting that there might be a higher risk of HCC in these untreated immune-tolerant patients. So what they did here is they compared on the left immune-tolerant adults and those that had immune-active disease, that's the group we typically treat, who were on treatment. So, and use that as the comparator. And you can see that the IT group in red had a higher cumulative rate of HCC than the treated IA patients. So they used that to sort of make and they adjusted for all the appropriate things. They did propensity matching, very, very well done study. in which they did sort of matching on the things that we know influence cancer, and they still showed there was about a 2.5 higher risk of getting cancer in that immune tolerant group. So that kind of messaging really frightens most practitioners. It's like, I'm not going to have my patient get cancer and, you know, pull the trigger for treatment. But, you know, the devil's always in the details, and I just want to show you that if you look at what are these immune-tolerant patients in this study, I would say they are the patients that currently we would say probably have to go on treatment. So you can see the mean age of their immune-tolerant patients was 38. So, you know, that's that 30 to 40-year-old group that we're sort of all struggling with. That's probably the time we should think about treating. And if you look at their HBV DNA levels, about 26% had low HBV DNA levels. Low typically means they're already transitioning to immune active. So I would argue that probably what this study shows you is that as people get older, as they're more transitioning to immune active, they really are patients that we should treat. So it's really helping us to understand that don't just say immune tolerant, I don't treat. Now you have to look at the age as well. So the sort of take-home message is really pay attention to age. And I would say over the age of 30, that's generally the immune-tolerant patients that we're now moving towards doing treatment. Okay, so what to treat with? As you know, we do have PEG interferon. Most of us don't use it. Of the 3 oral therapies that are available, we have Entecavir, TAF, and Tenofovir DF or TDF. And in truth, great options. All 3 drugs, very well tolerated, all achieve very excellent suppression of HBV DNA. And the guidance document has kind of suggested when you might choose one over the other. And in general, you are going to choose either Entecavir or TAF, meaning avoid TDF, in somebody who's got risk factors for either renal or bone disease. That's the primary differentiating factor. And then obviously things like, you know, what was their prior treatment history? Do they have HIV infection? Those things would also influence some of your treatment choices. But in general, most of the patients you're going to see, they'd be well served by any of these drugs. But then this past year, a very controversial study, I think, was published. And I wrote an editorial on it. And I have to say, I had a very cautious editorial. It's more like, wow, it's a really well done study. But I still kind of can, in my mind, understand the biological reason for it. And what the study suggested is actually there's a difference between our sort of approved drugs in terms of their ability to prevent cancer. So this was published in JAMA Oncology, and what this study showed, and I'm showing you actually the revised paper. This generated a huge uproar. There was a lot of individuals wrote about the paper, and there was actually an error in the analysis, which the authors then retracted the original paper and resubmitted. So this is the newest data. It doesn't change the main message, which is that the TDF, compared to the Entecavir treated patients when you adjust for all of the other variables that are important, had a 30% lower risk of HCC, suggesting TDF has an advantage over Entecavir in terms of the risk reduction for HCC. What changed in the paper is they also showed a mortality benefit, but that actually did not hold up in the reanalysis. So this was a study that sort of started it, and I have to say that I sort of like, well, why? Like, they're both getting suppression of HBV DNA. Why is there difference? And I can honestly say there's some hypothesis, but I don't know the answer. But it has generated more studies, which is exactly what in my editorial I had said, is that I said, this is interesting, but we need more data. So in the recent meetings, there's been several very large studies. This is, I think, the best done of those that have been done in the interim. This is nearly 30,000 patients from Hong Kong. And they did exactly the same thing. Very well done study where they carefully matched patients who received Entecavir versus those that received Tenofovir DF, and then looked at their incidence rate for HCC. Now, at the baseline, the Entecavir versus the TDF patients are older, more males, more advanced fibrosis. So they do have more risk for HCC at baseline, but they did very careful matching and showed that in their propensity matched HCC evaluation, indeed, TDF, again, had a lower rate of HCC compared to Entecavir. So they, too, kind of confirm those results. So these are, I think, very kind of rapidly evolving. I still feel like we need more data, but I think that this is really sort of now coming. We're seeing strong data consistently. It's an interesting area, so stay tuned. And then lastly is this idea of stopping treatment. So I've told you how to start. This controversy with start, the controversies with what drug to use, and now when to stop. And I'd say this is where there's been the most activity. And it really relates not too much to the cirrhotic patients. Everybody agrees we should treat those patients with nucleoside analogs forever. E antigen positive, no controversy there either. Basically, you treat those individuals till they seroconvert. Then you consolidate by treating them for another year or so and then stop. But where the real controversy is in the E antigen negative patients, where right now, guidance documents, at least in ASLD, says you should treat those patients until they lose surface antigen. And what that means, in fact, is you treat them forever because they don't lose surface antigen. But EASL and APOSL were much more willing to consider stopping in that group of patients. And EASL says you can stop after 3 years, APOSL says after 4. So basically they say treat, have suppression for a period of time, several years, normal ALT, and then you can stop. And why would they do this? Well, part of it is they actually think the stopping will enhance the likelihood that the patients will lose surface antigen, because we do that very infrequently with suppressive therapy. So that's sort of the rationale behind it. So it all was sort of, I think, put into motion with this study that was presented and then published 2 years ago now. But I'll just review it with you just so you know what sort of started it. It was a very modest study, 21 patients, where they compared people on TDF for 4 years and then stopped them versus those that just kept on the TDF. And if you look at the very far, which is 4 years after they've stopped, what you can see is that about 20% of the patients have lost surface antigen, which is amazing, and 2/3 of the patients remain off treatment because their HBV DNA levels remained low and their ALT levels are really normal. So it suggests that actually about 2/3 to 3/4 of patients can indeed come off treatment and don't need to go back on it. So that is in fact important information. But, you know, whenever there's one study that says it works, there's always another study that says it doesn't, and this was presented this year. It's the Canadian trial. They did the same thing, but they did not get the same response. They had very few. They had really essentially none of their patients, actually only one lost surface antigen, so a very low rate of surface antigen loss, and they ended up retreating a much greater proportion of patients. So you can see the retreatment group on the right, and this is only 72 weeks after stopping, not 4 years, but they'd restarted treatment on about 40% of patients already, and they only had a sustained sort of response in about 30%. So they got a different experience and had a lot more retreatment that went on. And so they suggested that maybe it's just we have a different population than what they have in Europe, Europeans. Canadian population is probably more like, especially this is a Toronto study, it's like LA. It's largely an Asian American population for the most part. And so they sort of thought maybe that's why we're not seeing the same results. But I just put it out there to say there's some inconsistencies here. And the other thing is that you just got to know that all of this stopping of treatment leads to a lot of ALT flares. So here's what happens when you stop, and you can see the retreated group is on the left, and some of them had their ALT levels that went 15 times the upper limit of normal. So this is not for the faint of heart, this withdrawal stuff. And so, you know, you've got to be monitoring these patients very carefully because this is potentially your risk. Of course, there is some that ultimately get the desired benefit, but you're going to get flares and you need to actively manage them. And there's some real problems with the studies. They're heterogeneous, the patient populations. They use different NAs and different durations of suppression. And the rules about when to restart the NA therapy when they're flaring are also very variable across the studies. The flares seem to be important, but you know, good flares versus bad flares you know, are worthwhile. I'm aware of a patient who was withdrawn who ultimately flared bad enough that they needed a liver transplant. So we see that, and that's what we have to be kind of aware of. So the sort of bottom line on this withdrawal of therapy is that I would say it's not ready for prime time yet. We still need more studies to help us delineate how we do this better. I'm going to shift in my last 2 minutes here just to say the new frontier really is about losing surface antigen. So mapped out here is kind of the natural history of hepatitis B from left to right. Currently, our treatments are put somebody on therapy and suppress their virus. But very few of those individuals lose surface antigen. And now there's a big move towards cure for Hep B. And cure here is defined by loss of surface antigen without acquisition of surface antibody. And you're going to hear this term functional cure. That's the term we're using to define the endpoint for which we're going, which is the surface antigen loss. And with that, of course, suppression of HBV DNA. You'll also hear the term partial cure. That refers to somebody who doesn't lose surface antigen, but who has an undetectable HBV DNA off treatment. It's a pretty good intermediate endpoint. And you also hear the term sterilizing cure. That's when you actually not only get rid of surface antigen, but you get rid of the CCC DNA within the nucleus of the hepatocytes and integrated HBV DNA, which is in the host DNA. We actually don't know if that's even achievable yet, but it's still on the docket as something to consider. And this is data that I think says suppression is good, but loss of surface antigen is even better. And again, this is the Hong Kong cohorts, a very large number of patients. And you can see on the right, this is looking at patients who were on suppressive therapy with NAs. And some of those individuals lost surface antigen and then were taken off, and some continued being suppressed. And this is a very long study with treatment out to 8 years. But you can see on the bottom, the group that loses surface antigen is the group that has the very lowest rate of events. In this case, we're looking at cancer again. You can see it's only 1%, whereas that suppressed group still remains at risk. So that's why it's now this idea that we really need to get sort of a more complete version of cure, which surface antigen loss captures. So how are we going to get there? Currently, our therapies very infrequently lead to surface antigen loss. So we clearly need new tools in the toolbox, and this diagram just highlights the number of drug classes that we have available. And just to highlight, we have drugs now that are interfering with how the virus enters the hepatocyte. We have some targeted therapies for the cccDNA, but in particular where we're seeing a lot of new therapies are in how we are interfering with transcription and or translation of the virus and or release of virus. And I'm going to just take 1 minute to give you a little sense of what these drugs look like. There are probably 20 that are in various forms of phase 1 and phase 2 study. Very early. Very few have made it to phase 3 yet. But here's just to give you a flavor. This is one that's interfering with transcription. This is silencing RNAs that interfere with the transcription. The idea is you reduce the sort of these viral proteins. These in turn kind of lead to an upregulation of the immune responses, and ultimately that gets us where we want to go. And just to give you a sense, this is one molecule. It's called JNC 3989. A very short duration of treatment. This is a subcutaneous dosing, so they used 4 different doses from 1 to 100. And just to give you a sense of what's happening here, this on the left is showing the decline in the surface antigen level. So this isn't virus, this is surface antigen level. So you can see with just 3 doses, we get these really marked declines in surface antigen that even after the treatment is stopped, seem to be sustained. So pretty encouraging early results, very early. Here's another drug. This is a drug, they're called NAPs. They actually block viral release from the hepatocyte. So you've got a mature virion, but they're not, now you're going to try to block how they're released. And again, just to give you some sense, this is surface antigen level data. So looking on the left, you can see that the treated patients marked reductions in surface antigen levels and the acquisition of antibody. And in this study, of the 40 patients that have been treated, 58% of them are surface antigen negative. So that's a very high number with a relatively modest treatment. This one was combined with Tenofovir and PEG interferon. So just to summarize, that's just a little glimpse of the future. My summary for Hep B is that we've got very good drugs. There's this interesting idea about whether there's a difference in terms of the HCC risk, and you should keep your eye out for more data. In terms of stopping rules, a lot of interest in withdrawal of treatment. I would be very cautious in doing that. Think about functional cure. That is the new mantra in terms of where we're going for hepatitis B therapy. Infrequently achieved currently, but the new drugs look incredibly exciting. So lots to stay tuned for. Thanks very much.